Welcome to the Student Association of the ACOFP's 30 for 30. I'm Michael Page, and I'm ACOFP President of the Student Association. My co-host today needs no introduction. It's Thomas Duffy from the Board of Governors.
Thanks for having me, Michael. Today we're going to be watching 30 videos selected by the Student Association, representing different hands-on OMT techniques, all in approximately 30 minutes.
That's right, folks. So get ready to refine those OMT skills and warm up those palpatory hands. We're going to get right into it with the upper and lower extremities, and then we'll move on to the lumbar.
Let's go.
Anterior lateral malleolus muscle energy. Patient is supine on the table. Physician is either seated or standing at the foot of the table. The physician's thumb should contact the lateral malleolus and push in a posterior fashion. The other hand should contact the foot and encourage dorsiflexion. The patient should then be pushing in plantar flexion, push down like a gas pedal, and the physician resists the impulse and relax. This should be held for 3 to 5 seconds and repeated about 3 to 5 times. And push again and relax. And then the dysfunction should be reevaluated.
Now we will discuss the treatment of a posterior C1 vertebra. First off, take your patient, raise them up some. If they have long hair, you can clear it out of the way to allow better access to the top of the neck. Take your hands and feel for the C1 vertebra right at the base of the skull and translate backwards and forwards to find the dysfunction. For this patient, she has dysfunction on the right-hand side. It is caught backwards posterior. I cannot bring it back around towards the left. To treat this, I put my fingers under the spine, right at the base of the skull by C1, C2, and I make a small anterior motion gapping the C1, C2 interface. I'm gonna take her, bend her a little bit to flexion, and side bend towards the left, have her turn into my hand for 3 to 5 seconds. 3, 4, 5, relax, engage the next barrier, and do this about 3 to 5 times. Relax, and again, and relax. Once this is done, put them back easily into a point of neutrality and recheck for resolution.
Articulatory treatment for a posterior clavicle. Contact the patient's clavicle and grasp their elbow. We want to put a downward force on the clavicle while drawing the arm back to further exaggerate the posterior clavicle dysfunction. While compressing into the clavicle with the elbow, we want to draw the arm anteriorly to go through the barrier and replace it back into its neutral position.
Seated bilateral rib raising. I'm going to have the patient clasp their arms in front and lean on my shoulder. I'm going to reach around to the back of their ribs, make sure I'm off the transverse process and on the rib cage on both sides. And I'm going to ask them to take deep inhalations, and I'm going to lean back as they breathe in and let them breathe out and let them come back to a seated position. Breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. And as you achieve better motion, you can move up and down the thoracic spine, treating the entire rib cage.
Articulatory treatment for an anterior clavicle dysfunction. Place your hand on the clavicle and grasp the patient's arm. Give a downward force through the clavicle and take the arm anteriorly to exaggerate the dysfunction. Then take the patient's arm in a sweeping motion, nice and smooth, through the dysfunction to replace the clavicle into its normal position.
Now that technique was a real breath of fresh air.
Refreshing indeed.
Regional and segmental examination of the lumbar spine. Palpate the paravertebral muscles on either side of the spine in the lumbar region, feeling for symmetry, tension. Then place your thumbs on each segment individually. Place your thumbs over the transverse process. Alternate pressing anteriorly on the right, then the left, feeling for rotation, ease of movement, and restriction. Then assess translation and side bending by bringing your thumbs lateral to the transverse processes and pressing gently to the right, then to the left. Repeat for each segment. Then place your fingers on each of the spinous process. Press with your thumb over the finger on the spinous process anteriorly, feeling for a restriction of movement.
This is lumbar dysfunction still technique. We will be correcting L2 on L3, extended rotated side bend right. The patient starts sitting on the table, their back closer to one edge. The practitioner is standing behind the patient on the side opposite of the dysfunction. We will start by identifying the dysfunction with our right hand, our monitoring hand, at L2, with our thumb and forefinger on the transverse processes. The left arm will either be draped across the back of the patient's shoulders or, if more comfortable, across the front. We will first start by placing a downward vector force through the shoulders and the spine to L2. We will then start this technique indirectly by extending the patient, side bending and rotating to the right while maintaining the downward vector force to L2. Once all the forces are stacked, this will then become a direct technique where we rotate the patient into the barrier towards the left with side bending and rotation, maintaining that downward vector force into L2 until the barrier resolves. And then we will bring the patient back to neutral and reassess at L2 for improvement of motion and tissue texture change.
Reassessment is so important, Tommy. It's great to see a classic named after our founder, A.T. Still.
Be A.T. Still my beating heart. That was a perfect example of such a crucial technique.
Anterior thoracic cage release, anterior approach. This approach to the anterior thoracic cage release is good for patients who are hospitalized when it's difficult to get to the head of the bed. The hands are placed with the palms of the hands over the 4th through the 6th ribs, with the thumbs pointing towards the sternum. The fingers are reaching up over the clavicles and resting on the upper ribs. This position may be challenging in patients with breast tissue. You may want to consider doing the approach from the head of the bed where breast tissue can be avoided. Once you're in this position, you're going to engage the fascial barrier, taking your hands through different planes of motion, including cephalad, caudad, and cephalad, finding the ease of motion. Then you're going to take the patient through some internal and external rotation of your hands, finding the ease of motion, and then lateral, medial and lateral motion, finding the ease of motion. Once you have found the balance point between all of these motions, stacking into the direction of ease, you're going to hold. You can apply some anterior posterior pressure to help augment release, or have the patient take a deep breath. Blow it out. And continue until a release is felt.
All right, folks, we're about a third down with our 30 for 30 countdown. Let's talk about what we've seen so far, Tommy.
Oh, we've seen some great techniques so far, Michael. Those last few, we're talking about lumbar back pain. It's not only the most common reason why patients seek OMT, but it's also one of the ones best supported in the current literature.
Absolutely, Tommy. And coming up next is thoracic techniques.
This technique is anterior thoracic tender points in the lower thoracic segment. These tender points are actually underneath the costal margin. So you would again place your finger until you felt where that tender point was. And you would ask the patient again to abduct their arm and internally rotate their shoulder while you add flexion to the neck. And this time it would be even more flexion and you introduce side bending to the trunk in order to be able to soften that tissue, as well as you ask your patient to bend their knees and put their feet flat on the table. And in that way, you've been able to make sure that all of the tissue is as soft and unrestricted as possible. You would wait your 90 seconds, then ask the patient to put their legs out straight again. And then you would bring them back to neutral. How's that feeling?
Good.
This is the Crisscross HVLA, also known as the Texas Twist. We do this for patients that are complaining of upper to mid back pain. You start with the patient prone, and I start this out as a soft tissue technique where I place the hypothenar eminences of my hands on the transverse processes, which would also be along the paraspinal muscles. And I'll apply cephalad as well as caudal traction to my hypothenar eminences, trying to work out some of the tension in the paraspinal muscles. I'm also noting if I feel a somatic dysfunction or a rotated transverse process as I'm doing this. So I am noting that Tammy has one right about at T7, and I know that because I'm at the lower edge of her scapula. So I place this pisiform bone at the T7 transverse process, and then with my other hand, I place it at the segment below, or T8. Then I apply force to be able to meet the barrier. So I'll go cephalad and lateral and a little anterior to be able to engage that barrier. And then I'll ask the patient to take a deep breath in, and I'll follow her into exhalation, and then apply a very quick, high velocity, low amplitude force, cephalad and lateral, to be able to change the rotation of that transverse process. And then I'll reassess to make sure that the dysfunction has been fixed. This technique is thoracic anterior tender point in the mid-thoracic area. First, you assess for the tender point. For anyone with breast tissue, you would want to start in the midline and then work laterally to try to avoid the breast tissue. Once you find the most tender spot, then you want to fold and hold around it by making the tissue around it as small as you can. So first I'm going to ask Tom to abduct your arm, as well as to then internally rotate your shoulder. Great. Then I'm going to add flexion by lifting his head, and I'm going to add just a little bit of a side bending component to it. And I can even add a little bit of a rotational component to it to make sure that I am relieving that pain. If you still feel like there's tension there, you can ask the patient to put their feet flat on the table and flex their knees to add additional flexion from below. After the 90 seconds, you go ahead and put the patient back into a neutral position, and your finger is just there to make sure that you are reassessing where the tender point was.
Well, it's just like they say, Michael. Sometimes you got to know both when to hold them and fold them at the same time.
Certainly, Tommy. I'd bet big on that technique every hand.
Anterior thoracic counterstrain for points T1 through T6. For this treatment, your patient will lie supine, and the physician will stand either at the side or the head of the patient, depending upon comfort. To find the tender points, you will palpate down the sternum at the level of the corresponding ribs. Once you find the tender point, you will cup your patient's head and neck in your other hand. You will flex up to the necessary amount until there is a 70% reduction in tenderness.
Once here, you will hold this position for 90 seconds and then passively return your patient to neutral and recheck.
Segmental diagnosis of thoracic somatic dysfunction. To find the area of greatest restriction, you can simply do a wiggling mobilization of the thoracic spine. Wherever it wiggles the least is going to be your area of significant dysfunction. Once there, put your fingers on the spinous process and transverse process in that area, and then simply take the patient into rotation. So he prefers rotation to the left, side bending. He prefers side bending to the right, flexion and extension. Flexion and extension are fairly neutral. It does not worsen the dysfunction. So we have a rotated left, side bent right, thoracic dysfunction. To find the level, you could either use landmarks or simply count down through the thoracic spine. So starting up at 1, you can count the spinous processes down, or you could always start at rib 12 and count up to the dysfunction.
Thoracic inlet myofascial release from the head of the table. Physician is at the head of the table with the thumbs on the posterior aspect of the first rib. The fingers should reach across the clavicle, engaging the fascial barrier. You're going to take the thoracic inlet through 3 planes of motion, finding the point of ease or the point of restriction, depending if you want to do the technique direct or indirect. For a direct technique, we're going to take the patients through flexion, extension, engaging the barrier at flexion. We're going to take the patient through side bending and rotation. Stacking into the barrier for direct. You're going to hold the position until a release is felt. Breath can be used to help accentuate the release. Please take a deep breath, blow it out. This can be repeated for several breaths until you start to feel the tissues release.
He started out that patient rumbling, bumbling, stumbling.
Agreed. Last time I saw that many tender points, I was walking out of level 1.
Okay, let's do cervical articulatory technique. We're going to previously have a diagnosis. In this case, it's C3, rotated right, side bent right in extension. I'm going to place my hands at the level of C3 at the cervical pillars and control only C3 on C4 and lift his head slightly off the table so I can move him in a position of the barrier, which is side bending left, rotation left, and flexion. Once I'm there, up against the barrier, the articulatory portion is bouncing through the barrier in either a rotational, so a small circle, or in a figure 8 until you improve motion at the level of C3. Once you think you've finished the technique, you bring them back to neutral and reassess to make sure you've improved range of motion at C3 on C4.
Congratulations for surviving Thoracic Park. We're in the home stretch now, folks. Just 1/3 to go. How you feeling, Michael?
I'm feeling great, Tommy. I tell you what, from those love me tender points to that Texas twisting, I'm really feeling like we're rocking and rolling now.
Well, keep those joints loose, because up next is cervical with sacrum on deck.
Cervical facilitated positional release. For this technique, we're going to treat C5, flexed, rotated right, side bent right. Your left hand in this case is going to palpate at C5 in the cervical pillars. You're going to neutralize the cervical spine, and then the hand on top of the head, my right hand, is adding a compressive force down till I feel motion at C5. I now move them into the diagnosis, which is side bending to the right, rotation to the right, and flexion. In this position of ease, I hold them with the compression force for 3 to 5 seconds. I relax the compression and bring them back to neutral. Finally, I check the somatic dysfunction to make sure we've improved the dysfunction. Supine cervical diagnosis. Standing at the patient's side, you may have to learn how to diagnose a cervical spine. For instances like being in the hospital or in a situation where you can't get to the head of the bed. First thing you want to do is palpate for tissue texture change and asymmetry, range of motion deficits. So you feel the cervical spine, feel the paraspinals, and find areas of interest that you'll further investigate. To know what level you're currently palpating, your index finger would be at C3, C4, C5, and C6, and you can move one level down for C7 or one level up for C2. Once you find an area of tissue texture change, you can locally translate that level and feel for a range of motion deficit, and you can move the whole head in rotation and side bending down to the level that you're trying to diagnose. For typical cervical vertebra, C2 to C7, the rotation and side bending is at the same side and may be coupled with flexion or extension. So while you're palpating that area and you found that in this case he's side bent left and rotated left, you can add flexion or extension, and if either improves the situation with the range of motion deficit or the tissue texture change, then you know that they are in that position. So if it gets better with flexion, you know that they are flexed, rotated, and side bent to that side. Next, you're going to palpate the AA and the OA. First, for the AA, you're going to find the transverse process of C1. You find that between the angle of the mandible and the mastoid process. Palpating in, you can feel that transverse process and then have him rotate, or you can rotate his head to the right and rotate his head to the left. If you feel a premature stopping of motion, or you feel tissue texture that gets tighter at the side of the dysfunction. Lastly, controlling his occiput, you can do motion testing of the occipital atlanto joint in all four directions of motion of that joint to describe and define what your dysfunction is at the OA.
This technique is cervical muscle energy. You initially diagnose the somatic dysfunction in the C-spine. Then you place the knuckle of your index finger in the area of dysfunction. You extend or flex to the barrier at that segment. You side bend to that segment as well as rotating to that segment. Then you ask the patient to both rotate and side bend their head into your thumb, and you hold it for 3 to 5 seconds. Ask them to relax. Then you bring them to the next barrier. Again, extension, side bending, and rotation. And again, ask them to push into your thumb, holding it for 3 to 5 seconds, asking them to relax, and going to the next barrier. And you'll repeat that for 3 to 5 times, always holding it for 3 to 5 seconds, and very important to allow relaxation for a second or two between the techniques, then engage the next barrier. And always reassess to make sure that the dysfunction has been treated.
This is anterior cervical lymphatic techniques. First, you're going to grasp the patient's head and neck and do a slight stretch to loosen up the soft tissues and help you find the sternocleidomastoid muscle. Slightly turn them away from the side in which you're going to do the technique, and you'll do a soft effleurage on the sternocleidomastoid, which is where the anterior cervical lymphatic chain is found. Several repetitions. Do the other side, bring them back to neutral, and you're done.
Hello there. Today, we're going to discuss the atlas and axis. The atlas is the C1 vertebra. It can be caught either turned towards the left, where it's anterior, or to the right, where it's anterior on the left-hand side now. Looking at the atlas, first off, you're going to cup the patient's head, elevate slightly, bring all the hair up out of the way to allow full access to the neck itself. Come at the base of the skull, cradle down to find C1 and C2, the atlas and the axis. Take your hands and translate backwards and forwards, trying to move that vertebra to see how it is moving and how is it restricted. Hers is having a problem on the right-hand side. It's caught more anterior or towards the left because it cannot push it back down towards the right. So having this on the right-hand side is being problematic. I'm going to give a little flexion to the neck until I feel a point of relaxation. I'm going to turn towards the left until I feel that point of relaxation. Have her turn her head right into my hand for the count of 3. 1, 2, 3. Relax. Engage the next barrier. Turn. Relax. And again, using an unyielding counterforce. Relax. Put her back down easily to a point of neutrality. Check again. Make sure it moves well.
Tommy, no better way to find a roadmap for the win than to take a look at that atlas.
And how?
Muscle energy for the occipito-atlantal joint. First, with any muscle energy, you want to go directly into the barrier. So in this case, we have an OA joint that is side bent right, rotated left, and extended. You want to find the lateral process of C1 by going between the mastoid and gonion. Your middle finger will drop right into the lateral process of C1. So if we're side bent right and rotated left and extended, we want to take it into the barrier. So we want to side bend left, rotate right, and then we also want to flex a little bit. Once in this position, the patient attempts to straighten their head. Please take your head back to a straight position. And relax. They're going to hold for 3 to 5 seconds. And go ahead and push, 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 push. And relax. And we're going to go one more time and push. And relax. And then we're going to take them back to neutral and reassess.
Next, we will be diagnosing ribs 1 and 2. Your patient will start off laying supine, and you'll lightly contact and find the point where rib 1 inserts at the base of the neck. You can see that on her it is approximately here. And then rib 2 is just a little lateral anterior to the scapula at this point. For you to diagnose the rib, again, lightly contact with your thumb, and on rib 1 as it inserts at the base of the neck, just apply a gentle inferior force. If you feel a nice springing motion, the rib is moving well. However, if you meet a sudden endpoint, that means the first rib is elevated. Again, move laterally, just anterior to the scapula, find rib 2. Apply an inferior force, and if it springs, rib 2 is moving well. If you meet a sudden endpoint, that means rib 2 is elevated.
Prone high velocity, low amplitude technique for ribs 1 and 2. For this technique, we're going to treat a rib dysfunction on the patient's right side. I'm going to contact that rib with the hypothenar eminence of my right hand. I'm going to place the patient's head in a position on their chin, slightly to the left of the midline. I'm going to side bend their neck and head to take up slack as I have them take a deep breath in and out. I compress into the rib. I do not further push on the head. My thrust is through my hypothenar eminence with a quick downward force into the table. Bring them back to neutral and reassess.
Anterior sacrum, muscle energy. Patient position, lying on their side on the treatment table with their hips and knees flexed. Physician position, standing at the level of the patient's hips, facing the patient. Example, left anterior sacrum. Place the pads of your index and middle fingers over the patient's left sacral sulcus to monitor the dysfunctional sacroiliac articulation. With your right hand, grasp both of the patient's legs just above the ankles. Flex their hips until you palpate motion occurring between the sacrum and ilium in the left sacroiliac articulation. Further flex the patient's left hip and allow their left leg to drop off the side of the treatment table. This produces external rotation of the left hip and introduces side bending of the sacrum to the right. It also rotates the sacrum to the left between the ilia. Contact the patient's left leg with your right thigh to stabilize them on the table and to maintain the introduced side bending and rotation. Switch your monitoring hand and palpate the patient's left sacral sulcus with your right hand. Grasp the patient's right arm above the elbow with your left hand and pull toward you until you palpate left sacral rotation in the left sacroiliac joint. Maintain the left rotational forces applied to the sacrum by releasing the patient's right arm and contacting their left anterior shoulder with your left forearm. Keep your left forearm in contact with the patient's left shoulder and again switch hands so that you are monitoring the patient's left sacral sulcus with your left hand. Contact the patient's left iliac crest with your right forearm and rotate their pelvis toward you, rotating the pelvis to the right with your right forearm, while maintaining sacral rotation to the left from above with your left forearm. The patient is now instructed to push their pelvis back against the holding force of your right forearm and/or to push their left shoulder against your left forearm for 3 to 5 seconds. Maintain your holding force during the patient's contraction. Instruct the patient to relax for 2 to 3 seconds. Further increase pressure through your right forearm to rotate the patient's pelvis further to the right, while maintaining sacral rotation to the left by holding their upper torso with your left forearm, as above in step 11, to re-engage the barrier, and repeat steps 12 through 14 as many times as necessary to establish the desired sacroiliac range of motion. When the procedure is completed, reassess the dysfunctional area.
A real classic there from the ACOFP 30 for 30 archives.
That's right, and I'm so glad that we're living in a time when they've invented colors besides brown.
Muscle energy for anterior innominate dysfunction. Patient is supine. Physician stands at the side of the table on the innominate to be treated. The top hand should palpate in the sacroiliac joint. The lower hand should contact the patient's knee to get control. The thigh should be flexed until there is a barrier. The patient then pushes for 3 seconds. Please push for 3 seconds. And relax. And in that 1 second, the thigh should be put into more flexion. And push again, please. And relax. This should be repeated 3 to 5 times, and then a reassessment can be done. Treatment of the sacroiliac ligaments. Patient is supine, physician staying on the side of the table that you want to palpate the ligaments. Move the patient's hand out of the way. Lift the knee up a little bit. Seated on the side of the table, you slide your hand underneath the sacroiliac area, and then you simply abduct and adduct to feel how the motion of the innominate is freely on the sacrum. If there's an area that's more stiff or doesn't move as well, you can just stay at that position, put a little bit of force down through the femur to make sure the innominate is moving on the sacrum as much as possible. If you feel this soften normally, then you can stay there. If you have any trouble at any specific spot, you can always use muscle energy as an assist to help this move better. So in this case, when we can't adduct as much as we need, go ahead and push your knee to the right, please. 1, 2, 3, and relax. And push to the right. 1, 2, 3, and relax. This should be carried through, and the entire sacroiliac joint should be evaluated by raising the leg up and down, as there could be dysfunction at one or more spots throughout the joint. This should be done anytime you are treating the innominates or pelvis, so that the ligaments are not an inhibition to any other treatment you may want to do, such as muscle energy or HVLA.
Excellent technique there, Tommy. Very useful in the clinical setting. And we all know the hips don't lie.
Well, I, for one, will plead the fifth. And there you have it, folks. That's the buzzer. What a historic event. Thank you all for joining us at home and watching along.
Absolutely, Tommy, and thank you for joining in with me today as we looked at the ACOFP's 30 for 30. We really got in there, really dug deep. We went all the way around first base with first year, through second on to third, and brought it home with fourth. A great journey through the OMT textbook.
Yes, indeed. I think we made the Lightning Bone Setter proud.
Certainly, Tommy. And if you guys out there are looking for more resources just like this, be sure and visit our website at acofp.org for a full library of OMT videos. It's a great way to expand your skill set. And that's it for this year. Tune in next year for ACOFP's 30 for 30.